Welcome everybody to my channel. I'm going to present a case of off-pump CABG with 6 grafts. This is the coronary angio. You see the LED is CTO, 2 OMs, Remus, and a high diagonal. This is the right, has mid-segment subtotal lesion. The LED fills retrograde. So in this case, I did 6 grafts of pump. So I think this is the best case to explain the almost all tips and tricks for off-pump CABG. I'll do my best to explain everything. This is after harvesting the mammary and opening the pericardium. I usually take 3. Here I noticed the LV contractility is not that good. I informed the anesthesiologist. I usually take 6 pericardial suspension stitches, 3 on the right and 3 on the left. There are some tips about the pericardial stitches. Okay, this is the left upper stitch. We usually don't pull on this stitch unless we need urgent cannulation. Sometimes we need to pull on it. Otherwise, we usually leave it loose. The upper right stitch, I usually fix it to the pectoral muscle. And the best place to fix this stitch is the pectoral muscle, not the skin, to avoid the skin to be rolled in. The aim of this stitch is to get the aorta at higher level or at more superficial level. So if you put it on the skin, all what you do is that you will invert the skin inside and you will not pull the aorta outside. The other 2 stitches on the left side should be as deep as possible. So when you pull on them, you get the heart not only toward the surgeon, I mean not only outside, but also toward the surgeon, slightly to the right. This is the right lower pericardial stitch, and usually I leave it loose. Then the left lower stitch, I take good bite as deep as possible. Sometimes I take it on 2 stages. This is the first bite and I pull on it. Then I elevate the heart and take it deeper. This is the same stitch, the left lower stitch. This allows me to elevate the heart and get it towards me, so it facilitates exposure of the all the lateral surface, and I mean not only the lateral surface but also the LED, lateral surface targets, and the LED, OM, Remus, and so on. This is very important. This is opening of the right pleuropericardial reflection. This allows the heart to herniate to the right lung while doing the lateral targets, so it avoids hemodynamic instability. Generous incision is made, opening the pleura, and I do it in all cases in which I have a lateral target, OM or ramus. All the reflection should be opened. As I said, this allows the heart to herniate to the right side, to the right pleura, so it avoids compression of the heart between the octopus and the right pleuropericardial reflection while doing the lateral targets. I continue by opening the pleura generously. So it's like an L shape opening. As you see, the heart is herniating in the right pleura. This is a very important step in all patients with lateral targets. Usually I don't start with the lima to LED unless the patient is left main. I know most surgeons start with lima to LED, but usually I don't do so, and I have a reason. If you started with lima to LED, it makes exposure of the left or the lateral targets, it makes the exposure limited, because you have a lima to LED crossing your field, and this may stretch the lima to LED. Now I have a look at the targets. Okay, I have two OMs, ramus, diagonal, and LED, in addition to the PDA. Okay, I'll go step backward and continue my idea about why I start with the lateral targets, not the LED. First of all, to facilitate exposure of the lateral targets, and second, to allow, I don't like to use the distal part of the LED. I usually like to use the middle part of the LED, of the lima. I like to use the middle part of the lima because it is wide enough and it has it's not spastic. So if I started with lima to LED, I will have to use the distal part of the lima to have enough length to allow for easy anastomosis of the lateral targets or easy exposure of the lateral targets. So that's why I don't start with lima to LED unless the patient is left main. Here the contractility is not that good, so I ask to open a central line to put a femoral arterial line just in case I need an intra-aortic balloon. Okay, moving down to the femoral, palpating the femoral artery. And now I'm going to put an arterial line, femoral arterial line, just in case. The blood pressure is borderline, so I'm asking the anesthesiologist to raise the blood pressure. Okay, I got my puncture. Introducing the guide wire. Make sure that the guide wire is going smoothly with no resistance. Then I put the dilator. Okay, then the CVP. All the lines should be flushed with Hepsaline.
نص على ايه اسلام الست ليه؟
Now I'm going to fix the CVP. I'm changing my gloves because I used those gloves at the groin, so I'm just changing my gloves. Here I'm just wasting some time because I was waiting for my retractor. And by the way, this is one of the most important points. I use the CTS guidance retractor. Not always, but this is my my preference. It gives me a wide range of movement for the octopus, as you will see. However, other retractors are fine. You can use Medtronic. You can use Coolie retractor. You can use the Morris retractor. All of them works. Here I'm widening the incision, making it larger, checking the shunts and the silastic, checking the shunt sizes. Here the shunt silk is torn, so I'm going to tie in another one. Unfortunately, we have to use all those shunts to reuse them, sterilize them, because we don't have the luxury to open new shunt for every case. In this case, I have to use different sizes, and I have to make sure that the size is suitable for the coronary. And let me talk about the shunts. The shunts are very important. Their importance is that, first of all, they allow me to work on the coronary without ischemia. Second, they prevent air embolism. Third, they protect the angles, and they make sure that the anastomosis is done properly. Their disadvantage is that if the size is not suitable, they may cause, if oversized, they may cause dissection in the coronary. If undersized, you have leakage from all around. Here I'm checking the lima, and by the way, one of the advantages of making lima to LED after finishing the OMs is that you give chance for the lima to vasodilate using the vasodilators, papaverine, and so on. Here the lima is closed with a clip distally, and I apply warm saline with vasodilators, and I leave it till finishing the lateral targets, so giving enough time for the lima to dilate. Also, I hemostase the lima before doing lima to LED to avoid any clips after doing the lima to LED. Sometimes those clips may cause dissection, or they may cause some sort of stenosis in the lima. So make sure you hemostase the lima, then check the flow. Then after doing lima to LED, try not to touch the lima. As I said, I don't like to use the distal lima, and doing the lateral targets first allow me to use the middle part of the lima, not the distal. Okay, checking the length. Pulsations are fine. Applying warm saline with vasodilators, not only to vasodilate the lima, but also, as I said, to check that there are no branches that needs clipping, because after doing the lima to LED, as I said, do not touch the lima. No clips after putting lima to LED. I use a blue cannula. Why blue cannula? Because it makes the saline going at stronger pattern. So this hitting the lima strongly with the warm saline makes more vasodilatation than if we used a wide bore cannula like the gray one. So this is my routine. I'm wasting some time actually waiting for my retractor, the CTS retractor. Having another look at the targets, the PDA. I'm sorry for all this wasting of time, but here I was waiting for my CTS guidance retractor. Now I'm checking the air and the suction of the octopus. Then the vein. I usually avoid doing the anastomosis close to any of the venous valves. Actually, if I have the luxury of using a segment of the vein with no valves, I will probably do so. I do believe that the valves plays an important role in esophageal venous graft failure, either early failure or late failure. Okay, here I'm checking the vein. I make sure that the distal end there is no valves, the vein. I'm sorry for all this chaos. Okay, finally, I got my retractor, I think. Okay, this is the CTS guidance retractor. This is my preference. It gives wide range of movement for the octopus. It allows you to position the heart easily, especially when you are using a Mackey octopus. I use Mackey or Medtronic. I like the Mackey by far. I like the Mackey very much more than the Medtronic. The Medtronic has some limitations. Actually, it's not the time to explain that. However, the Medtronic is not as easy as the Mackey. So when you have the Mackey octopus and the CTS guidance retractor, you can do any position safely. It makes life much easier. Also, the CTS guidance retractor has its own, this stitch organizer, the stitch holder, so makes it easy to fix the stitch at any time. Here I'm checking the octopus. Unfortunately, we also use the octopus not a single use. We have to sterilize them, so sometimes you have issues related to the suction. You have to reattach the suction tube to the octopus and so on. I know this wastes a lot of time, but actually we don't have the luxury to use a new octopus for every patient, so we have to do so. Now I'm fixing the suction tube to the octopus leg. Once again, I'm sorry for all this waste of time, but I have to do so. Okay, now I'm going to have a look at the OM. In this patient, we will do OM1, OM2, ramus, and diagonal, LED, and PDA. So when you expose the lateral targets, you pull on the left lower and left middle pericardial stitch. The anesthesiologist gets the head down and the patient slightly towards the surgeon, and this makes the exposure great. Now we have general rules to put the octopus. The target vessel should be in the middle between both legs of the octopus and parallel to them. Take your time in putting the position. Notice that the heart here is herniating in the right lung or right pleura, so you avoid the tamponade effect. Don't be in a hurry. Don't open the coronary unless you are quite sure that you see good and that the anesthesiologist is happy. Avoid using inotropes. Don't put the heart in a stressful position that pushes the anesthesiologist to put inotropes. Try to adjust your position as much as possible and as gentle as possible. Sometimes just few millimeters of compression or decompression of the heart, either to compress the heart toward you or decompress the heart, makes the hemodynamics better and makes the view better. Okay, this is my first target, OM2. You have to remove all the fascia or all the epicardium covering the target. During this time, I'm making sure that the patient hemodynamics are fine. So I take my time to remove the layer of epicardium covering the coronary, and during this time, I have a look at the hemodynamics to see if anything is going wrong. Also, don't depend on the monitor only, depend on your eyes seeing the heart. Make sure that the heart is beating at ease. Now I'm going to use the silastic to occlude the LED, the OM. As you see, I take the first stitch at the pericardium, then around the coronary. Why I do so? To make the direction of pulling on the coronary not towards not upwards, not towards the roof of the room. No, I make it towards the pericardium itself. So this avoids that the silastic obstruct your way or come through your field. Now I have a second look at the heart, the monitor. Make sure that I see the coronary properly. Have a look at the shunt size, the proper size I'm going to use according to the size of the coronary. As I said, the shunt size should be suitable. Okay, this is, I think this is 1.5. I make sure that the shunt is patent. As I said, we have to use those shunts, so just to make sure that everything is fine. During this time, I'm just making sure that the heart is at ease and no hemodynamic problem. Here I noticed that the heart is not good, so I relaxed everything and I started to have a look at the vein just to give the heart some time to recover from the position. Sometimes when you put the position at first time, the heart is not good, and then when you just leave the heart to recover and to remodel, and the anesthesiologist maybe he add a touch of NORAD or ephedrine, just giving the heart some time, and then you reposition the heart. It makes the exposure better, and the heart beats at more ease. Okay, positioning the heart once again. Okay, here I noticed that the silastic stitch, there is a locked stitch. It's okay, I can proceed even if it's locked, no problem. The site of the silastic stitch around the coronary should be at least few millimeters from the angle. Now I open the coronary with number 11 blade. Then I use straight pots. I like the straight pots in the OM and the Ramus, sometimes the LED. Okay, this is the straight pots. Then I use a reverse one or 120. And now I put the shunt. Sometimes it's a little bit difficult. Okay, the shunt is introduced. Once I introduce the shunt, I release the silastic to make sure that I'm not ischemic anymore. Then I start the anastomosis in a regular fashion. The first stitch is inside out through the vein, and the following point is very important. I usually start maybe 4 stitches before the angle, and why I do so, to allow my last stitch to be taken blindly, because the first stitch I take in the vein usually corresponds to the last stitch I take after finishing the anastomosis. So the last stitch I take it blindly, depending on that the vein is filled with blood, so I will not cause any stricture, and also depending on that I started away from the angle, because when you get close to the angle you can never take wide stitches. Notice here when you see the apex of the heart, you will find the heart is herniating at the right pleura, which avoids any tamponade effect between the octopus and the pleura. I hope it will come again. Okay, you see the heart is herniating a little bit to the right. I take the anastomosis in usual fashion, nothing specific. You see the heart contractility is better. The anesthesiologist maybe added some inotropes. I usually like NORAD or ephedrine. I don't like adrenaline. The most difficult stitch is the angle stitches, both angles. Those are the most difficult and challenging. You see here the octopus is not stabilizing the heart properly, not in excellent fashion. You know why? Because the octopus had to be maybe 1 centimeter deeper, 1 centimeter towards the proximal of the coronary, proximal of the site of the anastomosis. The site of the anastomosis should be in the middle of the between both octopus legs, and the octopus should have gone more away from the surgeon or more towards the proximal part of the OM. I mean more towards the silastic. Just half centimeter would have made it much easier. You see, very simple tips makes a big difference. So I take forehand stitches till I reach the angle, then I get then backhand stitches till I reach the angle once more, and then I shift to forehand. I usually like to do the anastomosis or wide anastomosis because I think this prevents stricture, and this is why I like to work without any hemodynamic problem, because I don't like to take the anastomosis in a hurry. Take every stitch at ease, everything under vision, put your shunt, and open the anastomosis widely, and so on. As you see, this is backhand till I reach the angle, then I will switch to forehand. Backhand. The angle tool the surgeon is taking in a different way. It's neither back nor forward. I don't know what to say or how to say it, but it's just an acute angle between the stitch and the castro or the needle holder. Okay, now I shifted to forehand. Just after crossing the angle, the first stitch is forehand. The angle is a little bit acute between the angle between the stitch and the castro. Now those are regular stitches in the usual fashion, nothing special. Before finishing the anastomosis with 1 or 2 stitches, I get the shunt out. All stitches should be taken under vision, nothing blindly, except the last stitch. Okay, now I'm going to get the shunt out. Check the flow is fine. And the vein is distended. Now this stitch I can take it blindly. The last 1 or 2 stitches I can take them blindly depending on the expansion of the vein. The vein is expanded. You see, this is lip to lip, as we say it, or as we call it, lip to lip. The edge of the vein is just in front of the edge of the coronary, so you can take them directly. Remember, I told you to start maybe 4 stitches before the angle, because this allows you to take this stitch, the last one, you can take it blindly. If you started close to the angle, you cannot take blind stitches. Close to the angles, you cannot take blind stitches, and you cannot take also deep stitches. It should be a little bit superficial to avoid making any stricture. Now I tie the stitch in the usual fashion. nothing special. I usually like to see the backflow in the vein. As you see, the vein is distended. This makes me happy. Now I remove this elastic. Okay, I'm checking the other lateral targets, seeing how to do the vein sequential. Usually I don't like sequential anastomosis. However, you don't have the luxury in 6 grafts put all those proximal anastomosis on the aorta, so you have to do some sequential anastomosis. Okay, now I'm checking the apex, checking for bleeding, checking the apex for contractility, and checking the anastomosis for any bleeding. Okay, looks fine. Checking the length of the vein and putting my plan. I like to open the vein widely and the coronary also. I like generous anastomosis. I don't like small one. Okay, now as you see, I'm moving the octopus, and that's what I said about the CTS guidance retractor. You have a wide range of movement. Okay, this is the ramus. It's intramyocardial, so I'm repositioning, putting some towels under the heart. Okay, the ramus, you have a very important point about the ramus. It is one of the most difficult positions and one of the most common positions to cause hemodynamic instability. So always remember that the stabilizer, the octopus, should be as a stabilizer. It should not be as a positioner. I mean, the octopus should be used just to stabilize the area or the 1 centimeter you are working at. It should not compress the heart hardly. Now I'm taking a stitch at the appendage just to get it outside my way because it was crossing my field. Okay, the ramus is intramyocardial. Its proximal part is calcific, so I have to go through the intramyocardial part. As you see, the octopus is not in optimum position. As I said, the octopus should be parallel to the coronary. I have to go deep in the myocardium because the proximal part of the ramus has an atheroma, so I have to go a little bit toward the intramyocardial part. Using air alone is not enough. You should use also water or saline, warm saline. Don't worry about the silastic. If it caused some sort of bleeding, usually it stops just with compression. Even if you penetrated the ventricle, don't worry, usually it stops. As I said, this stitch is at the left atrial appendage, just to get it away from my field. Okay, here I noticed some troublesome bleeding from the epicardium. So I'll just take a stitch just to make it easier while doing the anastomosis. I'm checking the suitable size shunt. Also, I check the 1.5. Okay, 1.5 and 2. The wall is not that good, so I have some trouble with opening the coronary. As you see, I use street pots, the same I used in the OM. Now I'm trying to put the shunt. The proximal part of the ramus was heavily calcific, so the shunt having some troubles to put the shunt. So, and I don't like to put it roughly or through a calcific area, so I will just remove it and work without the shunt. I will reuse it when I reach the distal angle, just to protect the distal angle. I'm trying another shunt, different size. Actually, this is the same size, but a little bit more rigid. Okay, it passes distally smooth, however, proximally I'll have the same problem. If I had the shunt 1.5, 1.25, it would work. However, I didn't have this size, so I'll just continue working without the shunt. Another trial. Okay, I realized that I will dislodge the atheroma, so I will just work without the shunt. Here I'm trying to extend the incision a little bit through the atheroma. Maybe the shunt can go. That's too scary. I released the silastic just to make sure where is the true lumen. Now I decided to work without the shunt because it's too risky to try to put it by force. Okay, as usual, inside out through the vein, about 4 stitches before the angle. You know my mistake here. I should have gone far away from the atherosclerotic part. I should have dissected more over the intermyocardial part of the coronary, and I should have did the anastomosis at more distal part with more healthy wall. But this is how it goes. Now in the usual fashion, as I said, forehand stitches until you cross the angle by 1 or 2 stitches, then you will shift to backhand. Backhand, as I said, after crossing the angle, you shift to backhand. Also, one mistake in this anastomosis, the octopus should have gone more. The same mistake I did in the last, in the previous anastomosis. But you know, by time you get used to this beating fashion, and it's okay. Now I will put the shunt to protect the distal angle, because the distal angle here is very important. I try to put it proximally, the same problem, so I'll just put it while doing the distal angle to make sure that it's patent. I released the silastic, so I had a gush of blood, so I had to put the silastic again. Now I continue 1 or 2 stitches, then take another trial to put the shunt at the distal angle. I take the stitches here a little bit deep, and I get out through the epicardium I have dissected as some sort of hemostasis. You see, I take the muscles with me, but I don't do this at the angle. 1 or 2 stitches before the angle, I just take the coronary only. As you see, when you put the heart in a good position, you can take your time, the anastomosis. You are not in a hurry. Take every stitch under vision. When now I'm just probing distally because I didn't put a shunt, so I put the probe distally to make sure that I didn't cause any stricture or something. Now I release the elastic. As you see, the vein is distended, which means that the proximal flow is fine. This makes me feel good. I was a little bit worried about this anastomosis because I didn't put a shunt, but having this distended vein and this flow makes me sure that I didn't cause any stricture proximally. And distally I passed a probe, so I'm just quite sure that I didn't cause any stricture distally. The most important rule is to cause no harm. That's to say, your anastomosis should not cause any new strictures, because the patient will not tolerate an acutely added lesion. Okay, I'm checking the vein for sequential anastomosis. Now I have a diagonal. When you have two close grafts to each other, you cannot do sequential. So sequential needs the graft to take its its curvature, its angle, so it needs some length. So you cannot do sequential anastomosis in two close grafts. This is either a ramus, you can call it what as you like. It's either a ramus or a high diagonal, and the previous done anastomosis. Okay. Okay, I decided to do the sequential anastomosis first between the ramus or the first OM and the diagonal. So we have some rules in any target. We try to avoid any calcific areas to do our anastomosis. If you have a calcific region and you have to pass through, make sure that you have a landing zone, a good landing zone, non-calcific, before and after the calcific area. So if you have a focal lesion with calcification and you have to do your anastomosis at this area, so make a wide incision before and after the calcific area. Make sure, in another way, make sure that the angles are not calcific. Okay, now I'm going to the sequential anastomosis. Actually, the previous anastomosis I have done, it was not for ramus, it was for OM1. Okay, this is sequential anastomosis between OM1 and the diagonal. Adjusting the angles is very important for sequential anastomosis. Adjusting the length of the vein is very important. Make sure it's not kinked. Of course, you should avoid opening the vein at any valves. Usually the valves are close to the silk knots or to the vein tributaries, so avoid opening the vein close to any of its tributaries. Choosing the appropriate shunt. Putting the shunt distal first, then proximal. Releasing the silastic. I put the silk of the shunt on the other side, away from me, starting 3 to 4 stitches before the angle. So with this anastomosis, you will notice that it is crisscross. I mean, the angle of the vein will be at at the middle of the coronary, not angle to angle as usual fashion. You see, this is the angle of the vein will be at the middle of the coronary, not angle to angle. As usual, before the last 1 or 2 stitches, I remove the shunt and release the elastic and take the last 1 or 2 stitches blindly. You see here, I hold the stitch of the shunt uh, uh, just upwards and toward my assistant. This makes the last 1 or 2 stitches much easier. Now I remove the shunt and I take the last 1 or 2 stitches blindly. Lip to lip. For doing sequential anastomosis, the size of the vein should be good. You cannot do sequential anastomosis with very small vein. Should have a good size, because otherwise if the vein is small, it will flatten. Okay, repositioning. Okay, have a look at the length. Here I decided that I will need an extra vein because I still have a ramus and a PDA for the venous grafts. So I asked my assistant to continue harvesting another segment of the vein. Yeah, I'm helping my second assistant to get the vein out. Okay, now back to repositioning of the heart. To do the ramus. So the first anastomosis done was OM2. The second anastomosis was OM1, sequential with the diagonal. And this is the fourth anastomosis for ramus. I had a problem with the blower here, so just trying to fix it. I had to go a little bit intramyocardial for this ramus. Okay, it looks a little bit white, unhealthy. I have to start at my incision at a healthy area. Checking the length of the vein. As I said, I don't like to use the vein with valves, so I just cut the vein at the valve and exclude the valve, making sure that the length will be enough. Open the vein generously. Okay, I use the pots. Okay, putting the shunt distally first, then proximally, releasing this elastic. Then starting the anastomosis in the usual fashion, 4 stitches before the angle, inside out in the vein, then inside out in the coronary using the other arm of the needle, going all through, all the way around. As usual, nothing special here. As usual, Now you see I hold the stitch of the shunt and pull it towards or push it toward my assistant. It makes the exposure much better. I use this 3 to 4 angles before, 3 to 4 stitches before the last stitch. Then I remove the shunt and I take lip to lip stitch blindly. No need to expose both edges here because they are opposite to each other and the pin is distended, so you don't have a chance to make the anastomosis to make a stricture in the anastomosis or something. At this point, my anesthesiologist is asking if I'm going to do the PDA. I told them don't forget that we still have a Lima to LED, and we had a debate why not to do the PDA first. Here I told him that yes, I don't start with Lima to LED to make it easier to expose the lateral targets, but Lima to LED is important, you know, it's the most important. So I will not go to the inferior targets, or the right targets, either RCA or PDA, without doing the Lima to LED. In case of PDA, the Lima to LED is not crossing my field at all, so there is no advantage of postponing Lima to LED. Okay, now I have a look at the LED. Put the octopus in the same fashion. The coronary between and in the middle and parallel to the octopus suckers. Fixing some issues with the octopus. You see here, I will not use the distal part of the Lima. If I started with Lima to LED, I would have used this distal part. You know why? Because doing the lateral targets after the lateral targets, I mean the OM and the ramus and the diagonal, after putting the Lima to LED, you will have to stretch this, the anastomosis will be stretched and it may rupture and cause troublesome bleeding. So if you are going to do Lima to LED first, you will have to have some length at the memory. You cannot use it just at the suitable length. No, you have to have extra length to give yourself a chance or a space to do the lateral targets. I usually put a shunt at not only at the coronary but also at the Lima, to make sure that the angle is patent and to make sure that the angle stitch will not cause any stricture, and I will not take the posterior wall or include the posterior wall in my stitches. You should also use for the shunt in the Lima, undersize the shunt. I mean, if the lima is 2 millimeter, for example, use 1.5. If the meter is if the lima is 1.5, use 1.25 shunt. It should be undersized to prevent any dissection. Okay, I'll start in the same fashion, 3 to 4 stitches before the angle. I usually take this stitch before dissecting on the lima, on the LED, sorry. That's why, just to save some time, few seconds, because I want, after opening the LED, to be ready to start the anastomosis immediately. I usually pull on the silastic and count for 1 minute. Ask the anesthesiologist to set the timer for 1 minute to make sure that no hemodynamic instability or ischemic changes because of closure of the LED. However, in this case, the LED is CTO, and usually those patients does not have any hemodynamic problem with closure of the LED. Now after getting the lima down, I call this two shunt technique. I have a shunt in the lima and shunt in the LED. I take a few stitches in this with both shunts. A shunt in lima, as I said, and a shunt in the LED. I take a few stitches after crossing the angle of the lima, while the shunt is still in the lima, to make sure that I don't cause any stricture in the lima. I usually use non-touch technique. Finally, we are getting to the last anastomosis, the PDA. Usually I don't fix the lima. Sometimes I do, sometimes I do not. Surgeon's preference, no rules for this step. For the PDA, I have to move the octopus towards the patient's head. So I put some towels between the IVC and the left pericardial stitches and elevate the heart as you see. Put the octopus and start dissecting over the coronary. Usually I prefer the PDA than doing the RCA. If I have chance to do the PDA, I do it. If I have to do the RCA, no problem, I can do also the RCA. However, I usually avoid to anastomose the RCA. Usually it's too big, calcific, atherosclerotic, and any dissection in the RCA is usually not well tolerated. So I usually avoid to anastomose the RCA if this is possible. If not, no problem, we can do it. As you see here, I take the silastic stitch at the diaphragm then around the coronary. This is for the same reason, to make the direction of pulling over the coronary not obscuring my field or not crossing my field. So I fixed the vein with an small syringe needle, usually an insulin syringe needle. Why I do this? Just to make both hands of my assistant free, to be able to help me. He can follow the stitch by one hand, or take it the Becky by one hand, and the other hand having the air. You see the anastomosis here is a little bit close to the octopus sucker. This is not an optimum position. The anastomosis or the coronary should be just midway between both suckers of the octopus, midway and parallel. This is the optimum position. Neither close to one of the suckers, nor perpendicular, for example, to one of the suckers. Should be just parallel and exactly in between. As you can notice, I put the heart in good position, so I can see properly, and at the same time I don't have any hemodynamic problem. This is the optimum position. The optimum position is the position that the surgeon can see every single stitch and can work at ease. At the same time, the anesthesiologist is happy, is not adding too much inotropes, and is not suffering with the hemodynamics of the patient. Okay, now I finished all the distal anastomosis and I will start arranging or planning for my proximal anastomosis. So in this case, we have a lot of proximal anastomosis, so we have to plan it very well. In off pump, the proximal anastomosis is different from on pump. In off pump, you don't have the luxury to put the C clamp taking a wide bite of the aorta, because taking a wide bite of the aorta may cause hemodynamic instability. One of the important things I would like to mention here is that I use full dose heparin, and after finishing all the anastomosis, including the proximal and removing the C clamp, I just reverse the heparin. I use half dose protamine. So I give full dose heparin at the beginning of the procedure with ACT above 400, and then after finishing all my anastomosis, I give just quarter or half dose protamine. I don't reverse the heparin totally. That's why, because as you see, I did the distal anastomosis first, and all the veins are filled with blood. So if I don't use full dose heparin, I will have some clotting starting in the veins. Here I noticed some clots, so I asked for to check the ACT and to give another dose of heparin. I started flushing the veins with heparin saline because of the clots I noticed. I'm going to open the pleuropericardial window. The aortopulmonary window. I'm going to open, yes, the reflection here. Here the aorta is big, so it I will not face a problem with doing my proximal anastomosis. If the aorta is small, maybe I won't have the luxury of doing 4 proximal anastomosis on a small aorta, so I will have to put a vein on vein. And that's also one of the reasons why I did one of the anastomosis sequential, because if the aorta will not have enough space to do 5 anastomoses, definitely this is impossible. Now I am checking the angles and the lie of the vein to make sure the length is good, and the angle of anastomosis of every vein. For OM, the angle of the vein should be at 3 o'clock. For Remus, 2 o'clock, and for sequential anastomosis, it's usually between 4 and 5 o'clock, and for the RCA, either 7 or 8 o'clock. For PDA, either 6 o'clock or 9. After putting the C-clamp, I take some time to dissect the adventitia over the aorta, and during this time I'm watching the hemodynamics very well and watching the heart very well, because if the C-clamp took a large bite of the aorta in off pump, be sure that you will have a hemodynamic problem. So just wasting some time to remove the fascia and make sure the heart is beating at ease, and the hemodynamics are fine, and also to plan where I'm going to put my 4 proximal anastomoses.